Breaking news in the endometriosis community. ACOG, the Medical Professional Society of the United States for OBGYNs, released a new guideline in March 2026 saying that we can diagnose endometriosis based on symptoms alone. No longer do you have to have surgery to diagnose endometriosis. This is incredible. This is a huge step forward for helping people with endometriosis. And I am so excited to share with you the details of this new guideline. I'm Dr. Lora Shahine, a double board certified OBGYN and reproductive endocrinologist, helping people with endometriosis for over 20 years. And this is a huge update and incredible move forward in my own career. I just cannot overemphasize this. If this is the first time finding my channel, welcome. I am so glad that you are here. And if you are coming back because you have found other videos on reproductive health and fertility and endometriosis helpful and valuable, that means the world to me. Make sure you subscribe to this channel so you don't miss my regular updates all about reproductive health and wellness. There are 2 other ways to stay in touch and learn together. You can sign up for my weekly newsletter in the description below, and you can listen to my Brave and Curious podcast anywhere you listen to podcasts. And I have the video interviews and deep dive discussions here on YouTube. What happened? Why am I so excited? In March 2026, the American College of Obstetricians and Gynecologists released a new practice guideline all about diagnosis of endometriosis. And it drastically changed what I had been taught in my medical school and my residency at UCSF in San Francisco and my fellowship at Stanford, and how I have been taught to practice my entire career. We have been taught over and over and over again that the only way to diagnose endometriosis is to see lesions surgically. You have to have a laparoscopy in order to get the diagnosis. Even if someone has such a clear history, symptoms that are absolutely classic endometriosis, or even relief from some medical or treatments. And we know that the relief from their symptoms is a sign that they have endometriosis. Just the dogma, it is just handed down generation after generation, guideline after guideline, that it had to be with surgery. And this shift is a dramatic shift to being able to diagnose someone without a surgery, and listening to patients and believing women when they share their symptoms. It's an incredible guideline, and I'm really excited to share the details with you. In today's video, we're going to go through some topics. Number 1, I'm going to give a review of endometriosis and let you know exactly how common it is. Number 2, we're going to go over the history and the historical perspective of why limiting diagnosis with surgery was so problematic and why it's so exciting to have this change. Number 3, we're going to go over ACOG's strong recommendation about using symptoms to diagnose endometriosis. I'm going to tell you exactly what they are. Number 4, ACOG includes imaging recommendations for diagnosing endometriosis. I'll share those. Number 5, we're going to go over why ACOG does not recommend using biomarkers like blood tests or endometrial sampling test to diagnose endometriosis at this time. Number 6, we're going to talk about laparoscopy or surgery and where it still fits into the diagnosis and treatment and equation of endometriosis. And finally, stick around to the end of the video where I'm going to teach you how to advocate for your care, because a lot of doctors and a lot of practicing providers of women's health are not going to be aware of this update. And unfortunately, it's not your job, but we have to advocate for our care. And I'll teach you how to share this new information in this guideline with your doctor to help you get the help you deserve. I will be sure to cite research if I share facts, and I will give references in the description of this YouTube video. I want to make sure you have access to all of that. Topic number 1, what is endometriosis and how common is it? Well, ACOG gives a definition. Endometriosis is a chronic inflammatory estrogen-dependent disorder defined by the presence of lesions of endometrial-like tissue outside of the uterus. That is a perfect definition. That is the way I describe it to my patients. It is tissue that, if you look at it under the microscope, it really looks like what you shed with your menstrual flow or the inner lining of the uterus, but it's found outside of the lining of the uterus, and it's found along the ovaries, outside the shape of the uterus, throughout the pelvis. And endometriosis can be found in any part of the body. There are studies showing that some women have found endometriosis lesions in their brain, in their lung, on scar tissue. It is something that we're still learning so much about, but it's chronic, it's estrogen dependent, it is an inflammatory condition. How common is it? I usually tell patients it's about 10% of reproductive age women. That's the most common quote that you'll hear. In the ACOG guidelines, they share it's anywhere from 0.7 to 8.6% of the general population have endometriosis, and certain subgroups of people could have a higher likelihood of having it. For example, endometriosis is found at anywhere from 9 to 68% of women with subfertility. I know that's a huge range. It just depends on which study you're looking at. 15 to 71% of women with chronic pelvic pain will ultimately be diagnosed with endometriosis. And in adolescents undergoing laparoscopy specifically for pelvic pain, endometriosis was identified 64% of the time. ACOG does a good job of listing risk factors for endometriosis, which I think is important to learn as a patient. They list 5. Number 1, early menarche, or getting your period before age 10. Number 2, short menstrual cycles, meaning cycles less than 26 days. Number 3, low body mass index. Number 4, Mullerian anomalies. These are uterine shape anomalies. This is something that you're born with. I've got some informational videos here on YouTube that can explain more about Mullerian or uterine shape anomalies you can be born with. And finally, number 5, family history. If your mom had endometriosis, if your sister or first-degree relative had endometriosis, you are much more likely to have it yourself. So endometriosis is not rare. It's affecting a lot of women and people that you know. An excellent review of endometriosis that ACOG actually references in their guideline is by Zondervan et al. In the New England Journal of Medicine, published in 2020. It's just called Endometriosis. So a lot of the facts that I have just said are going to be in that reference. Topic number 2, the historical harm that has resulted in linking a diagnosis of endometriosis with surgery. So for decades, and in my medical career for sure, the only way that someone could get a 100% diagnosis of endometriosis is if they had a surgery and you could see the lesions throughout the pelvis. The surgery that's done is something called a laparoscopy, and this is where a little camera is placed usually in the belly button and a couple of other small ports, like little incisions like this in the lower abdomen, and inflating the abdominal wall with CO2 gas so that you can look around and sort of see, are there endometriosis lesions throughout the pelvis around the reproductive organs? That is how it was diagnosed. I love that ACOG directly names the harm that has come from this linkage of surgery to diagnosis: diagnostic delay. On average, it takes women 7 to 8 years from onset of symptoms to getting a true diagnosis. And this delay in diagnosis leaves women in pain, leaves women feeling dismissed. It allows for the disease to progress, and we're missing valuable time and treatment options if someone doesn't have the diagnosis. Women are suffering, quality of life declines, and healthcare costs increase. ACOG goes further. They explicitly identify clinician-level barriers, and I'm quoting in the spirit of the guideline here: dismissal of patient's symptoms, normalization of pain, and misattribution of the patient's problem, all leading to delay in help. An excellent study that goes over these harms and delays with specific references is Davenport et al. From Obstetrics and Gynecology, published in 2023. The author's conclusion from the study is diagnostic delay in endometriosis is largely a product of dismissal of women's pain, outdated diagnostic models, not the disease itself. Topic number 3, ACOG's diagnosis based on symptoms alone. This is the exciting part, and this is what you've got to pay attention to. In the guideline, ACOG recommends that a clinical diagnosis of endometriosis made through a symptoms-based assessment, physical exam, or both is sufficient to initiate empiric medical treatment, and this is a strong recommendation from ACOG. So when they come up with guidelines. Medical societies will review all the research and they'll make recommendations, and then they will give a qualifier to sort of say, this is the recommendation, and this is either a strong recommendation or a not so strong recommendation, or kind of really qualify it. And they're saying, this is a strong recommendation. Pay attention. Surgery is no longer required to make the diagnosis. A clinical diagnosis is enough. Now, what symptoms does ACOG recommend paying attention to? They list 6 really strong ones at first. Number 1, chronic pelvic pain, defined as pain lasting 6 months or longer. Number 2, dysmenorrhea or severe period pain. Number 3, dyspareunia, which is pain with intercourse. Number 4, dysuria or painful urination or other urinary symptoms like hematuria or blood in the urine. Number 5, dyskinesia, which is painful bowel movements or postcoital bleeding. And number 6, infertility associated with one or more of the symptoms listed above. Another thing that does not necessarily have to be related to the period, and that is really important as well. Beyond this core list of symptoms that I just shared, there's 5 others that ACOG mentions. Number 1, gastrointestinal symptoms like bloating, diarrhea, constipation, nausea, or rectal bleeding. Number 2, thoracic symptoms like chest symptoms like shoulder or subcostal or subrib pain, and in rare cases, pneumothorax. That is where an endometriosis lesion, often in the setting of bleeding, will actually puncture the lung, and the lung will collapse based on endometriosis in the thoracic cavity. Number 3, sciatic nerve pain. So that's nerve pain that's kind of shooting down the leg because of the sciatic nerve being impacted and stressed by endometriosis lesions. Number 4, skin findings like surgical scar swelling. So a lot of people that have had laparoscopies and had little scars afterwards, we think it's from seeing the endometriosis lesions in the body, and then somehow the cells get seated in the scars, that sometimes people actually have endometriosis in their scars or swelling or pain in their scars after the surgical diagnosis. And finally, number 5, fatigue and malaise. Those can be chronic symptoms of endometriosis. 3 other things that ACOG mentions, especially for adolescents. School absenteeism, and so I would include that for adults, like missing work because you're in so much pain or having such difficulty with menstrual cycles. Number 2, dysmenorrhea or pain that does not respond to over-the-counter medications, something you can buy at the drugstore. Like one of the best medications for period cramps are NSAIDs, or like ibuprofen, Motrin, Advil. It's all the same thing. It's just sold under different names. Those are help decrease prostaglandins. Prostaglandins are what make your uterus contract. So those can be really helpful for period pain. And if you're having so much pain that these just do not touch it, that could be a sign of endometriosis. And finally, number 3, don't forget about family history. We already talked about a first-degree relative having endometriosis is a strong symptom or a suspicion of the patient that's sitting in front of you having endometriosis too. ACOG cites several research studies and why they've decided to use symptomatology so strongly. The one that they quote the most is Ballard et al., titled, "Can Symptomatology Help in the Diagnosis of Endometriosis? Findings from a National Case Control Study," from the British Journal of OBGYN, published in 2008. So we'll make sure you have all of these references in the description. Topic number 4, when does imaging help you understand and diagnose endometriosis? Basically, ACOG is saying imaging can be helpful. You don't have to see endometriosis on imaging to make the diagnosis. You can still do it clinically, but imaging can be helpful. First-line treatment is a transvaginal ultrasound. You can sometimes see a collection of endometriosis on the ovaries called an endometrioma. You can sometimes see inflammation, areas of collections of endometriosis. If someone cannot tolerate a transvaginal ultrasound, second line is an abdominal ultrasound. And they do talk about the use of an MRI that can be helpful, especially if you're thinking about planning for surgery. The MRI can give you a window into the extent of endometriosis and kind of help you with surgery planning. Now, I want to emphasize, not everybody needs an MRI. Not everybody needs a transvaginal ultrasound, but it can be very helpful in the process of diagnosis. And I love that they addressed that in this guideline. One tip that ACOG recommends is if you are getting an ultrasound for endometriosis, make sure and ask for the endometriosis protocol. So in a radiology department and with skilled ultrasonographers, they are going to use a different protocol and look for different images if they are searching for endometriosis. So that's a good part of advocating for your care. Make sure that when you're getting the images, that person knows exactly what we're looking for. Reminder, a negative MRI does not mean that someone does not have endometriosis. A negative ultrasound, that means you don't see any signs of endometriosis on ultrasound or MRI. You can still have the diagnosis. An excellent research study for that is by Nissenblatt et al. It's a Cochrane database systematic review from 2016 entitled Imaging Modalities for Non-Invasive Diagnosis of Endometriosis. The authors conclude in that article, ultrasound and MRI are valuable for detecting endometriomas and deep disease, but neither can reliably rule out endometriosis, particularly the type of superficial lesions that you're not going to be able to see on imaging. Topic number 5, biomarkers for endometriosis. In the field, people have been looking for ways to diagnose endometriosis without surgery, and lots of research into blood tests with biomarkers, endometrial biopsies with biomarkers. People are looking for it in menstrual blood. Really, people have been trying to find a way to help people get a diagnosis without surgery. And I love that ACOG directly references some of the modalities that are out there. One of the most common ones I remember being offered or recommended to check in my patients years and years ago is a biomarker in the blood called CA-125. And ACOG specifically calls it out and said, you do not need a blood test. CA-125 is not always going to tell you if you have endometriosis or not. There was a Cochrane review looking at this over 27 studies, more than 3,400 women looking at the CA-125 cutoff of greater than 35 to 36 units per milliliter, and the pooled sensitivity was 0.40. The specificity was about 0.91. Translation, roughly 60% of women with endometriosis will have a normal CA-125. So a normal CA-125 does not rule out endometriosis. So again, ACOG is saying, it's great that we're looking for non-invasive ways to diagnose endometriosis, but none of the biomarkers are really where they need to be. And let's just focus on symptoms. Topic number 6. Is there a role of laparoscopy for diagnosing and treating endometriosis? Absolutely. And ACOG talks about it a little bit in this guideline. The guideline mentions 4 cases where it really might be helpful to do surgery. Number 1, when the clinical diagnosis is unclear and there are other conditions that need to be ruled out, other GI issues or urinary issues, and you're really trying to figure out exactly what's causing someone's discomfort and pain. Number 2, when the patient desires a definitive diagnosis. This is a partnership, and the doctor and patient should be figuring out if surgery is right for that patient. Number 3, when empiric treatment has failed, so you've tried the lifestyle things, you've tried the medications, and you're still in pain, sometimes surgery can, number 1, make sure you have the right diagnosis, and excisional surgery of endometriosis lesions can relieve pain for a lot of patients. And finally, number 4, when concurrent treatment of identified disease is a part of the overall plan and goal for that particular patient. I'm so glad you stuck around to the end of the video. This is the most important part. You now have incredible knowledge that your doctor might not have yet, and I want to teach you how to advocate for your care. Here's the hard truth. A lot of doctors are not going to be aware of this. This is very new, and a lot of doctors are spending a lot of time taking care of patients in front of them, and they might not have gotten the message yet about this incredible guideline and how it changes the game. I've got 5 practical steps that could help you navigate this if you are running into a doctor that is not aware of the guidelines. Number 1, track your symptoms. Write down the symptoms that you're having. Grab the list that I gave you before. If any of those resonate, keep track of them, and in relationship to your menstrual cycle or not, just write down what is happening and keep track as you're waiting for your appointment. Number 2, reference the new guideline. You can say, I am familiar with the ACOG clinical practice guideline number 11, published in March 2026, which makes a strong recommendation for diagnosing endometriosis based on clinical symptoms. Here are all the symptoms that I'm having, and I'd really like to talk to you about making a diagnosis of endometriosis and helping me find relief. Number 3, ask specific questions. Based on my symptoms, do you think I have endometriosis? Can we try empiric medical therapy to see if my symptoms get better? And what do you think about doing imaging? I know that if imaging is negative, it doesn't show anything. That doesn't mean that I don't have endometriosis, but it might really help us figure out what's going on. Tip number 4, bring a partner or a support person to the appointment. Studies do show that patients are listened to more when there is a third person in the room. And number 5, if that first doctor or provider is dismissing you, making you feel bad for bringing up these symptoms and what you're living with, get a second opinion. And a little caveat to that, if your main symptom or something that you're really concerned about is your fertility, you're trying to get pregnant, you're having symptoms of endometriosis, that second opinion should be with a reproductive endocrinologist. That's me. So I am an OBGYN that did that for training, and then I did subspecialty training all about infertility, endometriosis, reproductive endocrinology. And if your goal is to get pregnant and have a baby, a diagnosis and treatment in line with endometriosis is really going to help you meet your goal sooner. And finally, just remember, you know your body best. Believe yourself and just keep tracking. Find that right doctor to listen. I really hope that this is helpful. So let's recap. Let's bring this all together and take it home. Number 1, endometriosis is a chronic inflammatory condition that impacts around 10% of reproductive age women. It most often presents with pain, sometimes infertility, and there has always been a delay in diagnosis because forever we've been told we have to do surgery in order to diagnose it. ACOG's new practice guideline, number 11, describes that we can diagnose endometriosis based on clinical symptoms alone. We went over a lot of those symptoms. Go back and listen and write them down and see what pertains to you. We talked about imaging, how ultrasound and MRI, not everybody needs it, but it can be helpful. We talked about how there's still a role of surgery or laparoscopy in the diagnosis and treatment of endometriosis. It just doesn't have to be required to get help sooner. And finally, I shared some tips on how to advocate for your care and really partner with your physician on feeling better soon. I hope you found this valuable. Please share this video with a friend and your loved ones that need to hear it. I really want to get this message out. Be sure and like this video if you learned something, comment with questions that you have. Be sure and follow this channel so you get my regular videos all about reproductive health, including endometriosis. And until next time, stay brave and curious.